In the intensive care unit, hemodynamic collapse requires rapid differentiation to avoid giving the wrong treatment. Example, giving fluids to a patient in cardiogenic shock. Point of care ultrasound or POCUS and echocardiography provide a non-invasive window into the patient's physiology, allowing you to categorize shock into 4 main types: hypovolemic, cardiogenic, obstructive like pulmonary embolism, and distributive, usually in sepsis. The most common framework for this is the RUSH protocol, rapid ultrasound for shock and hypotension, which systematically evaluates the pump, the tank, and the pipes. As the name implies, pump is assessment of cardiac status. Using the parasternal long axis, parasternal short axis, and apical 4-chamber views, you can assess the heart's function and structure. In hypovolemic shock, hyperdynamic vigorous contractions can be seen. Sometimes you see kissing of papillary muscles, that is, left ventricular walls touch each other in systole in severe hypovolemia with hyperdynamic contraction. In cardiogenic shock, it is hypodynamic or hypokinesia, poor left ventricular and right ventricular contractions. Dilated left ventricle, poor mitral valve excursions with the E-point septal separation more than 7 mm. Usually, when the mitral valve opens, it will reach almost up to the septum. Obstructive, you can see right ventricular strain in pulmonary embolism, or you could see signs of tamponade like pericardial effusion with right-sided chambers, diastolic collapse. And in pulmonary embolism with right ventricular dilatation, the contour of left ventricle changes from a circular to a D pattern. Increased pressure in the RV causes that. Pericardial effusion also can be seen. In distributive shock, which is often hyperdynamic, it can have late stage sepsis-induced cardiomyopathy as well. The M-mode echocardiogram at the bottom shows EPSS or E-point septal separation of the mitral valve echo. E-point is the maximum opening motion of the anterior mitral leaflet. Normally, it will reach almost up to the septum with only minimal separation. Increased EPSS means mitral valve opening excursions are low due to low cardiac output state. This M-mode echo also shows poor left ventricular contraction as evidenced by little movement of interventricular septum towards the left ventricular posterior wall. B-hump is seen in the motion of the anterior mitral leaflet, indicates high left ventricular and diastolic pressure in heart failure. Pericardial effusion marked as PE in the other image appears as echo-free space around the heart. The tank assessment looks at the inferior vena cava for volume status and leaks free fluid. A flat IVC less than 1.5 cm with high collapsibility, that is inspiratory collapse, suggests hypovolemic or distributive shock. A distended IVC more than 2.1 cm with no inspiratory collapse suggests cardiogenic or obstructive, that is tamponade or pulmonary embolism. Checking the leaks is by EFAST, extended focused assessment with sonography in trauma, because you expect bleeds in trauma. Check the Morrison's pouch or the hepatorenal recess on the right side, the splenorenal space and the pelvis for free fluid, looking for hemorrhage. Check the lungs for B lines in pulmonary edema, typical of cardiogenic shock. Lung sliding, if absent, it is pneumothorax, a cause for obstructive shock. The pipes, great vessels. This step identifies catastrophic vascular failures like scan for abdominal aortic aneurysm or intimal flaps of aortic dissection. Perform a 2-point compression scan for femoral and popliteal veins to look for deep vein thrombosis, which increases the probability of pulmonary embolism and obstructive shock. In the image, obstructed vein having thrombus with no flow on color Doppler is seen. Once again, to summarize the findings by the type of shock, LV function hyperdynamic in hypovolemic shock, hypodynamic or hypokinesia in cardiogenic shock. In obstructive, it could be normal or hyperdynamic, and in distributive shock due to sepsis, it is hyperdynamic in the early stage before the development of sepsis-induced cardiomyopathy. IVC size small or flat in hypovolemic, large fixed, that is without inspiratory collapse in cardiogenic, large fixed in obstructive as well, and small flat in distributive or sepsis. In the lungs, clear A lines are seen in hypovolemic, B lines in pulmonary edema of cardiogenic shock, clear or pneumothorax in specific types of obstructive shock, clear or focal B lines in sepsis, and free fluid in the belly can be noted sometimes in hypovolemic shock due to internal bleeding, and dilated left ventricle may be seen in cardiogenic shock, right ventricular strain, enlargement or pericardial effusion in obstructive shocks, and in distributive or septic shock you may see source of infection. Here are some diagnostic red flags to watch for. McConnell sign, akinesia of the right ventricular mid-free wall with sparing of the apex in acute pulmonary embolism. RARV, that is right atrium, right ventricle diastolic collapse of right-sided chambers indicating cardiac tamponade. E-point septal separation, measure the distance between the mitral valve, that is anterior mitral leaflet, and the septum in parasternal long axis view. In diastole, if more than 7 mm, the left ventricular function is likely severely reduced as shown in the previous mode image.